Hello viewers, I am Dr. Robiul. I work as a lecturer of pathology in a medical college hospital, and I am making this video for my students and also for you. Hope someone finds this helpful. Today's topic is acute lymphoblastic leukemia. This is the second lecture of our ongoing leukemia series. In this video, we will learn about the definition of acute lymphoblastic leukemia, the differences between lymphoblasts and myeloblasts, the incidence of acute lymphoblastic leukemia, its classification, pathogenesis, clinical features, prognosis, lab diagnosis, and towards the end of this lecture, we will also talk briefly about its treatment. Okay? A lot of topics, so let's begin. So first, we will talk about some introductory points regarding acute lymphoblastic leukemia. Now always remember, acute lymphoblastic leukemia is the most common cancer of children. Most of the cases occur in individuals who are younger than 15 years of age, and as we will see, they are slightly more frequent in boys than in girls. So now that we have talked about some introductory points regarding acute lymphoblastic leukemia, now let's define acute lymphoblastic leukemia. So how can we define acute lymphoblastic leukemia or lymphomas? These are neoplasms composed of immature B cells or T cells, which are referred to as lymphoblasts. Now, whenever you mention the term lymphoblast, the examiners are very fond of asking you, how can you differentiate between a lymphoblast and a myeloblast? And that's a very good question, and it is very important for your examination. We had already talked about that in our previous lecture of this series, but I am also recalling that here because that is very important for both your written and oral examination. So in this slide you can see the major differences. First of all, we have to remember that myeloblasts are larger, whereas lymphoblasts are smaller in size. Both have round or oval nucleus. However, the number of nucleoli varies. For example, in myeloblast, we can see that the number is between 2 to 5, and in case of lymphoblast, the number is 1 to 2, and often the nucleoli in case of lymphoblasts are very indistinct. So in this image, we can see a lymphoblast and we can also see a myeloblast. And can you see the major differences between these two types of blast cells? Yes, we can see lymphoblast has scanty cytoplasm and the nuclear chromatin are coarse. On the other hand, we can see that myeloblast has moderate amount of cytoplasm and prominent nucleoli. Regarding the incidence, always remember 85% of the cases are B-cell acute lymphoblastic leukemias or lymphomas, and they typically manifest as childhood acute leukemias. On the other hand, 15% of the cases are T-cell acute lymphoblastic leukemias or lymphomas, so they are less common and they typically manifest as thymic lymphomas in adolescent males. Now, the peak incidence for B-cell acute lymphoblastic leukemias or lymphomas is at about 3 years of age, and peak incidence of T-cell acute lymphoblastic leukemias or lymphomas is in the adolescence. However, as we will see, considerable overlap in the clinical behaviors of these two types are seen. So now that we have talked about the incidence of acute lymphoblastic leukemia, now let's move on and talk about the classification. Regarding classification of acute lymphoblastic leukemias, always remember there are two classification schemes. The first one is called morphological classification of acute lymphoblastic leukemias. It is also known as the FAB classification, and it was introduced in 1976. And the second classification scheme is WHO classification 2008 or World Health Organization classification 2008 of acute lymphoblastic leukemias or lymphomas. So let's talk about these two classification schemes one by one, and first we will talk about the morphological or FAB classification. According to this classification, we can further classify acute lymphoblastic leukemias into three subgroups. They are L1, L2, and L3. We can see that the size of the blast cells will be smaller in L1 and they are larger in L2 and L3. However, also note that in L2, the blast cells are large but heterogeneous, and in L3, they are also large but homogeneous. Regarding the nucleus cytoplasm ratio, we can see that it is high in L1, however, it is comparatively lower in L2 and L3. Regarding the cytoplasm, it is scanty in L1, and that's why we got the high nucleus cytoplasm ratio. However, we will have moderate cytoplasm in L2 and L3, and one particular important thing that you have to remember is that in L3 subtype, the cytoplasm is intensely basophilic. Regarding vacuoles in the cytoplasm, always remember that vacuoles may or may not be present in L1 or L2, however, they are prominent in L3 subtype. Regarding nuclear membrane, they are regular in L1 and they are irregular with clefting in L2, and they are regular in L3. Regarding nucleoli, they are invisible or indistinct in L1. However, in L2 or L3 subtypes, they are prominent and usually 1 to 2 in number. Regarding the WHO classification, we can see that here we have divided acute lymphoblastic leukemia or lymphoma under three broad headings. They are B lymphoblastic leukemia or lymphoma not otherwise specified, B lymphoblastic leukemia or lymphoma with recurrent genetic abnormalities, and the third group is T lymphoblastic leukemia or lymphoma. And in this slide, we can also see the recurrent genetic abnormalities. So this slide is summarizing the cytogenetic abnormalities that we see in B-cell acute lymphoblastic leukemia. Regarding hyperdiploidy, always remember that these are conditions where cells usually have more than 50 chromosomes, and they are the most frequent abnormality in childhood precursor B-cell acute lymphoblastic leukemia, and they generally have a good prognosis. They are associated with high sensitivity to chemotherapy, complete remission rate of 100%, and long-term disease-free survival in 90% of the cases. Now, what do we mean by hypodiploidy? These are cases where there is usually less than 44 chromosomes in the cells, and these cases have poor prognosis. Now, in the third bullet point, we can see that there is translocation between chromosome number 12 and chromosome number 21, and such translocation is the most common specific abnormality that we see in childhood B-cell acute lymphoblastic leukemia. And as a result of such translocation, there is formation of a fusion gene, that is ETV6 RUNX1, and the products of such fusion gene will repress the normal function of RUNX1 gene, and all these things will ultimately lead to development of B-cell acute lymphoblastic leukemia in the childhood. Now, in the fifth bullet point, we can see the translocation between chromosome number 9 and chromosome number 22, and the resultant chromosome is called Philadelphia chromosome, and we will talk about that in details in our next lecture on chronic myeloid leukemia. So for the moment, just remember that translocation between 9 and 22 is also sometimes seen in acute lymphoblastic leukemia as well. So now that we have classified acute lymphoblastic leukemia, now let's move on and talk about the pathogenesis of acute lymphoblastic leukemia. Regarding the pathogenesis, always remember that chromosomal aberrations dysregulate expression and function of transcription factors that are needed for normal lymphocyte development. And all these things lead to maturation arrest, and they also induce increased self-renewal. So this slide is summarizing the pathogenesis. In the center we can see a lymphoblast, and as we can see, apoptosis and differentiation of this lymphoblast has been blocked, and at the same time self-renewal is maintained or increased, and also proliferation is also increased, and all these things are leading to proliferative and survival advantage and blockage in differentiation and apoptosis, and ultimately all these things are leading to accumulation of undifferentiated cells. So now that we have talked about the pathogenesis of acute lymphoblastic leukemia, now let's move on and talk about the clinical features. So we can classify the clinical features under two broad headings: clinical features due to depression of the bone marrow function and clinical features due to organ infiltration. So due to depression of bone marrow function, there will be pallor and fatigue, and these are happening due to anemia. There will be also bruising, petechiae, due to thrombocytopenia, and there will be persistent fever due to neutropenia. Now, what are the clinical features due to organ infiltration? Bone pain may occur due to bone marrow expansion and also due to subperiosteal infiltration. There may be enlargement of the lymph node, that is lymphadenopathy, enlargement of the spleen, that is splenomegaly, enlargement of the liver, that is hepatomegaly. So all these things are happening due to organ infiltration. Central nervous system, testis, eye, gastrointestinal tract, and kidneys may also be involved. Now always remember, in T-cell acute lymphoblastic leukemias or lymphomas, complications related to compression of large vessels and airways in the mediastinum may also be seen. Now let's talk about the prognosis, and this is very important to know. Now this slide is very important for your examination, particularly for your multiple choice questions. The examiners are very fond of asking about the factors that are associated with favorable and unfavorable prognosis. So what are the factors that are associated with favorable prognosis? They will include age of presentation between 2 to 10 years, low white blood cell count, trisomy of chromosome 4, 7, and 10, presence of translocation between chromosome 12 and 21, and hyperdiploidy. This slide is showing the factors that are associated with worse prognosis. They will include age younger than 2 years, presentation occurring in adolescence or adulthood, and peripheral white blood blast counts greater than 100,000. So now that we have talked about the prognosis, now let's move on and talk about the lab diagnosis of acute lymphoblastic leukemia. Lab diagnosis will include blood picture and bone marrow examination, cytochemistry, immunophenotyping, and cytogenetic analysis. Regarding the blood picture, always remember, peripheral blood generally shows normochromic normocytic anemia and thrombocytopenia. Total leukocyte count may show leukopenia. normal leukocyte count or leukocytosis. Differential leukocyte count shows large number of circulating lymphoblasts, generally in excess of 20%. Lymphoblasts have round to convoluted nuclei, high nucleocytoplasmic ratio, and absence of cytoplasmic granularity. Some smear cells may be seen in the peripheral blood that are representing degenerated leukocytes. In bone marrow examination, we will see that the marrow is hypercellular and the marrow shows 20 to 90% cells are malignant undifferentiated cells of precursor B or T cell origin. In other words, 20 to 95% cells will be lymphoblasts, and we can demonstrate them by immunophenotyping, and megakaryocytes are usually reduced or absent. So this slide is summarizing the bone marrow findings of a patient of acute lymphoblastic leukemia, and as we can see, more than 20% of the cells are blast cells, or if you want to be more specific, lymphoblast. We can also see some cells of the red cell precursor series. However, note that there is almost no megakaryocyte. So we were saying that in the previous slide that in acute lymphoblastic leukemia, megakaryocytes will be reduced or absent in the bone marrow, and this slide is also showing similar finding. Regarding cytochemistry, always remember cytochemistry may be used as an adjunct to Romanowski staining for determining the type of leukemia. Periodic acid skip or PAS will be positive in immature lymphoid cells in acute lymphoblastic leukemia. There will be focal positivity of acid phosphatase in leukemic blasts in case of acute lymphoblastic leukemia. Myeloperoxidase will be negative in immature cells in acute lymphoblastic leukemia. Similarly, Sudan black and non-specific esterase will be negative in acute lymphoblastic leukemia. Now, in L1 and L2 subtypes of acute lymphoblastic leukemia, PAS positive blocks are seen in lymphoblast on a clear cytoplasmic background, and always remember that in T cell acute lymphoblastic leukemia and in L3 subtype of acute lymphoblastic leukemia, PAS reaction is negative. So in this image we can see the PAS positive blocks in the clear cytoplasmic background. Now, regarding immunophenotyping, always remember that immunophenotyping will help us in understanding whether the acute lymphoblastic leukemia is B cell origin or T cell origin. For example, in this slide we can see the markers that are positive mostly in B cell acute lymphoblastic leukemia. So they will include CD19, cytoplasmic CD22, cytoplasmic CD79A. These are positive in B cell acute lymphoblastic leukemia. Cytoplasmic immunoglobulin is positive particularly in the precursor B cell acute lymphoblastic leukemia, and we can also see that TDT, that stands for terminal deoxynucleotidal transferase, is positive in both B cell acute lymphoblastic leukemia as well as in T cell acute lymphoblastic leukemia. And this slide is showing the immunomarkers that are mainly positive in T cell acute lymphoblastic leukemia, and they will include CD7, cytoplasmic CD3, CD2, etc. So now that we have talked about the lab diagnosis, now let's move on and talk about the treatment of acute lymphoblastic leukemia. As we can see, we can classify the treatment of acute lymphoblastic leukemia under two broad headings: general supportive therapy and specific therapy. General supportive therapy will include insertion of central venous cannula, blood product support, and prevention of tumor lysis syndrome. And regarding specific therapy, we will talk about specific therapy in children and also about specific therapy in adults. Now, in children, specific therapy will include chemotherapy and radiotherapy. Treatment will take place in several phases. They will include induction, consolidation, and maintenance phase. And often induction phase is also known as remission induction, and consolidation phase is also known as intensification phase. So let's talk about these various phases one by one. So first we are talking about remission induction phase. The aim is to kill most of the tumor cells rapidly and achieve remission. Now, what do we mean by remission in case of acute lymphoblastic leukemia? This is very important. Always remember, in acute lymphoblastic leukemia, remission is defined as less than 5% blasts in the bone marrow, normal peripheral blood count, and absence of signs or symptoms of the disease. So what are the drugs commonly used in this phase? They will include vincristine, asparaginase, dexamethasone, and daunorubicin. Moving on to the next phase, and that was consolidation phase or intensification phase. And as the name implies, high doses of multi-drug chemotherapy are used in this phase to eliminate the disease or reduce tumor burden to very low level. Drugs commonly used will include vincristine, cyclophosphamide, cytosine arabinoside, daunorubicin, etoposide, mercaptopurine, and these drugs are given as blocks in different combinations. Now, this is also very important to prevent or treat central nervous system involvement. We have to provide central nervous system directed therapy or CNS directed therapy, and in order to do that we will use intrathecal methotrexate. So intrathecal methotrexate is used to prevent or treat CNS involvement. CNS relapse is treated with intrathecal methotrexate, cytosine arabinoside, and hydrocortisone with or without cranial irradiation and systemic chemotherapy. Moving on to maintenance therapy, always remember that such therapy is given with daily oral mercaptopurine and once weekly oral methotrexate. At monthly or 3-monthly intervals, intravenous vincristine with a short course of oral dexamethasone is also added, and prophylactic immunoglobulin should be given to children who are lacking immunity to varicella or measles. Now, always remember, in some protocols, maintenance therapy may be given soon after remission induction, and it is interrupted by periods of intensification chemotherapy. In typical regimens, intensive chemotherapy finishes around 38 weeks, and after that maintenance therapy starts again and lasts until week 112 in girls or week 164 in boys. Regarding treatment of relapse, always remember, if relapse is detected during or soon after maintenance therapy, the outlook is poor. Treatment options will include reinduction by combination chemotherapy, use of novel drugs, followed by stem cell transplant if possible. Regarding specific therapy in adults, always remember the rate of relapse is much higher in adults. Why? Because genetic subtypes of acute lymphoblastic leukemias differ with age. Another reason is that traditionally lower doses of chemotherapy have been used in adult patients. For cranial prophylaxis, intrathecal methotrexate with or without cytosine arabinoside and steroid is used, and high dose of methotrexate and cytosine arabinoside is also given systemically. And for BCR ABL positive acute lymphoblastic leukemia, specific tyrosine kinase inhibitor imatinib is used with chemotherapy. And if suitable sibling or matched unrelated donor is available, stem cell transplant is a treatment option for many patients with acute lymphoblastic leukemia. So this concludes our second lecture on leukemia. I hope this video was helpful. If you like my videos, do comment, share, subscribe, and let me know. And for my students, I will also recommend you to go through your textbooks to know more. Okay, that's all for today. Until next time, take care and stay blessed. Thank you.